Good morning. Thank you very much for joining us. Very good to have you with us after this time. And this morning's session is Your Care, Your Views, and it is a chance to share with you the feedback that we've had and to talk to you about our next steps and to provide a little more detail. So, as usual, the rules of the game are the same. So it's microphones muted, please, cameras off, and as this is a meeting that's happening during our period of public engagement, we're following the same practice, which is for you to submit your questions via the chat function to West Herts Communications. We are recording this session and it will be uploaded onto our YouTube channel where it will be publicly available and you can access it via our website also. So the aim of the session is to tell you about the feedback that we had during the first phase of our public engagement and to tell you where we're going to provide further information. We are going to outline services which are staying in their current location and those which are moving, because we know that is something that people wanted to know a little bit more about. We're going to tell you how you can stay involved with the programme and give you an opportunity at the end to ask questions. So our vision, as you will know, is for new and redeveloped hospitals, each with a distinct role, working together to provide a comprehensive range of hospital services for people in West Herts. And the broad outline is for Watford to provide emergency, specialist and complex care, St Albans to provide planned surgical care, planned cancer care and an urgent care service, and Hemel Hempstead to provide urgent and planned medical care, particularly focusing on patients with long-term and multiple conditions. And just to remind you that the minor injuries unit is temporarily closed and a programme of engagement led by Herts Valley's Clinical Commissioning Group will begin later this year, and that will determine the model of urgent care provided from that site. So, Helen, I'm wondering if you can do the next couple of slides as I inadvertently stole the first four from you. So I'm going to hand over to Helen.
Okay, last minute change of plan there and keeping me on my toes. Thank you very much, Louise. So we were really pleased with the amount of engagement we had in phase one, and we got lots of good feedback. So the things that respondents said to us, or what we heard from the survey, was that many people recognised the benefits of one-stop clinics and were pleased to see us thinking about building more diagnostics into the appointments, so fewer visits to hospital. We did hear about travel and access concerns, and we are going to do some more work on that. But in headline terms, what we heard from the survey was that people in Dacorum and St Albans are happier to travel between those two hospitals than to come to Watford, and residents of Watford and Three Rivers would prefer to use Watford General Hospital. But if they do need to attend Hemel or St Albans, they don't have a strong view about which one of those two hospitals it would be. We heard, again, quite a lot of feedback about the state of our buildings and the importance of us making improvements to our hospital facilities. And we did have some feedback about some anxiety about healthcare being delivered online. So we're going to provide a bit more information about those things as we work through this presentation, and I'm sure in the Q&A. Next slide, please. So in terms of what specifically we're going to be doing in this next phase of engagement and going forward, we want to provide some case studies from a patient perspective that will provide greater insight into the one-stop clinic model and our proposals for managing routine follow-up appointments. So that's what we call patient-initiated follow-up. We want to reassure the public that in-person appointments will still be available and that moving to online appointments is not compulsory. We're going to carry out some more targeted research to determine whether the results from our survey that we did in phase one are representative of the population as a whole. So we're going to do a targeted representative population sample and just look at whether there's any difference than the responses we got to the survey. We're going to conduct in-depth research with current and recent patients whose services are set to change location from north to south or vice versa, just to understand in a bit more detail what those concerns are and how we can help manage that. And we're going to continue to work to deepen our reach through community networks and give as many people as possible the opportunity to engage with us as we develop our services. And we're in the process of establishing a travel and access steering group and a reference group to really start drilling into travel and access and what improvements we can make. Over to you, Freddie.
Freddie, we can't hear you. Thank you. Thanks.
Sorry, should have learned by now. My name is Freddie Banks. I'm a consultant urologist and an associate medical director for clinical strategy at the Trust. I'm just going to talk you through the models for the 3 sites within West Herts and outline the benefits primarily for patients, but also for staff, of consolidating care on each of the 3 sites. So if we deal with Hempstead first, this is intended to be our planned medical care facility. This is effectively the non-surgical specialties. And what we're consolidating here so that we can do more one-stop clinics. We'll be improving the diagnostic capability at Hempstead, so there's faster diagnosis. We're putting things like DEXA scans in, upgrading the MRI, and also bolstering CT. We will also continue to provide urgent care on the Hemel site. The aim here is a focus really on patients with long-term conditions so that we can pull specialties together and really try and develop a model of care that we see patients with multi-specialties for long-term conditions to really try and get their care coordinated and integrated between primary and secondary care. New technology is a key factor with this, so that we can actually try and get as much of the diagnostics done on the same visit and improve what we're telling patients. That ties in with the one-stop clinics. Some of these will be multi-specialty. There's a very successful system in America called ChenMed, which is primarily primary care, but we're trying to do a more secondary care system based on this, which is integrated to really try and get the patients with multiple comorbidities. So that's patients who've got a degree of frailty, for instance, diabetes and rheumatological issues. We can try and get those specialties integrating so that patients get a really top class standard of care that then can be fed back to primary care and GPs so that we manage you better as well in the community. But it's just a much, much better system for integration and management. Concurrent with that is we're going to encourage patients to be much more in control of their follow-ups. There's a lot that patients can do to support the hospital. It's not a one-way system that we tell patients what to do. We want the patients to be integrated with their care, and that means much more involved in how their follow-up is planned and access to their notes and results and that side of things. We're going to have better places for staff so that the teams integrate and work better together, and we're planning the hospital build to facilitate that. And finally, we're improving some of the imaging, particularly with rheumatology, so that we've got DEXA scanning to create a rheumatology hub at Hempstead. These are the specialties that are going to continue to be based in Hemel, but also there'll be an upgrade of a lot of the other specialties. So there'll be probably more cardiology, a lot more diabetes, endocrinology, general medicine, respiratory, stroke, all of these specialties will be based primarily at Hempstead to provide the care. So there's a very much an upgrade in the facilities provided by the medical specialties. The same model is being planned for St Albans, but instead of being a medical facility, this is our planned surgical care facility. So this is all of the surgical specialties, general surgery, urology, ENT, ophthalmology, and orthopedics. Again, we're going to support with much better diagnostics. The clinical model favoured by the clinicians is very much to do one-stop clinics wherever possible to minimise the number of visits that a patient has to come to hospital. And again, integrated with this, we'll very much have the cancer support services. So our cancer nurses will all be there to support patients with cancer diagnoses. The key to this, as ever, is having really good diagnostics, which we've already increased at St Albans with the development of MRI and CT there. By creating a surgical centre away from the emergency centre at Watford, we hope that we can therefore facilitate patients' surgery so that it is timely, we can get the capacity management right, and if you get booked for an operation, it should never be cancelled because of a lack of bed, because your bed was taken overnight by someone coming in with an emergency. We're also going to plan to move the endoscopy centre there. The major advantage of this is that it will be co-located with the general surgical team. So if the gastroenterologists find cancer or something that needs surgery, you should have the opportunity to see a surgeon in the same building. The same applies from a urology point of view, my own specialty. We very much hope that if we can coordinate diagnostics and appointments together, it speeds up the pathway and will significantly improve the anxiety that occurs while patients waiting for results. And we can smooth out the patient pathway so that you've got a much easier pathway and single points of reference of where to go and where to find things. My own specialty, we using all sorts of hospitals to get the diagnostics. I long for the day when we can actually get all the diagnostics done under one roof. The patient literally walks ideally around the unit and can get all the diagnostics done in one day and then go home later on that day with the management in place, hopefully not needing surgery, but just be discharged with the reassurance that there's nothing going on. Running elective centres as pure elective centres should hugely improve infection control, and we should also be much more resilient to surges that occur in emergency care. See, that's been highlighted by COVID, the number of cancellations that have occurred. But in future, every year we get flu, pandemics or epidemics, or some form of infection control issue that then impacts on elective surgery, and we long to be protected from that, which should be available at St Albans with an enhanced facility there. As part of the redevelopment, we're planning to improve 2 theatres there, and we'll have expanded recovery areas and better flow of patients through the hospital, which will be a better patient experience. These are the surgical specialties and that will be based at St Albans. So I hope I'm not going to read through them all, everybody. And then to Watford. The bulk of the redevelopment will be at Watford, with the primary aim of providing a top quality emergency care facility. This is the absolute hub of the hospital. The vast majority of patients nowadays come into hospital through the emergency department, and we need a building that actually facilitates the delivery of emergency care. So we'll have all of the complex diagnostics there. It should be massively improved experience for both patients and staff. And we're very, very much organising all of the teams so that it is geared to being an emergency hospital with much better access to all of the specialties who will be geared up from a staffing point of view to facilitate seeing patients in ED. Watford is going to be the Women's and Children's Centre, so we'll have a completely new building for all of the obstetrics, the antenatal labour and postnatal care. The aim here is that actually you'll probably stay in the same room for your entire journey rather than jumping from ward to ward and delivery suites and then back onto postnatal care. Our plan is that this will be a much, much better experience for both mothers and newborn children. I've said already, the emergency centre, this will be a much better unit, be better equipped, a lot more assessment space. And the model here is very much that the specialists will come to see the patients rather than having patients shuffling around the hospital. And the aim, as much as possible, to get the assessments done quickly and rapidly, and ideally facilitate your discharge rather than your admission into hospital. If you do need admission, then you'll have all the facilities and backup that's needed. In order to facilitate this, there's a lot of staffing changes that are going on into how the teams are divvied up, with teams very much working their way through so that they're providing emergency cover and are available to. An example of this is just my own urology department. We've switched this week to a consultant of the week, so that we have a consultant now freed up on a daily basis to be able to go down to ED and see patients. Previously, we'd all be in clinic and doing having other commitments. So there's a very, very significant staffing component, but that will then be facilitated by the building. Paediatric services will also be based at Watford. The main ward will be there, and that dovetails in with the obstetric component, and also, once again, access to the children's emergency department, again, to facilitate, ideally, say, patient discharge primarily, but also admission. I think one of the really key changes about a new building is that we will have a very high number, probably in excess of 70%, will be single rooms. This will hugely help with infection control and patient experience. There's a huge amount of design that's going into this with the modern hospital, and that should keep patients much more protected and much better flow within the hospital, because we won't have to cohort patients into quasi-infected areas. And this building will be much more environmentally friendly. There's a big commitment possibly to a net carbon zero over the whole course of the building. And also, we are trying to plan rooms with as much natural light as possible, with outside areas and decent patient areas to actually get out of bed and be able to walk and socialise as well, to encourage patients to discharge from hospital. And again, I'm not going to read through the list, but pretty much every specialty, because of the emergency component, will have some degree of footprint at Watford Hospital. Now I'm going to hand over.
Thank you, Freddie. It's back to me now. So just a quick recap then of the main changes and benefits, and why we've been looking at this. So our existing configuration of services across the 3 hospitals is largely historical, and we don't think it is as well organised as it could be to meet the needs of our patients. Specialty clinical care will mostly be delivered from 2 sites rather than 3, so either Watford and Hemel or Watford and St Albans. And as Freddie said, the reason that it's generally Watford and Hemel or Watford and St Albans is because all the specialties need to be present on the emergency care site to support emergency care patients. All 3 sites will continue to provide outpatient appointments and urgent care, subject to the work in St Albans to just define that model. We really want Hemel to be our multi-specialty centre for multiple and long-term conditions. We think these changes will help reduce the likelihood of cancellations by separating out what we call hot and cold, so hot emergency and cold planned care, and strengthening the teams available on each site. We think it will support better training for staff, whether that's junior doctors, nursing staff, specialist therapy teams, improve team working and provide professional development opportunities. We want, as we've already talked about, the one-stop clinic model is really important, and getting really good diagnostic provision on each of the 3 sites is really important to support that one-stop model. Diagnostics at St Albans particularly aligning with the focus on cancer at that site and trying to make those cancer pathways much quicker and less stressful for patients. And the other benefit we see coming from this is that we'll see increased consultant presence at St Albans, which will enable us to undertake a wider range of more complex surgery at St Albans and provide better post-operative medical support. Next slide. So the next few slides that I'm going to talk through are just going to summarise what services are moving and what are staying, and we'll also summarise effectively what each hospital will look like, and this information is available on our website. So in terms of west to east move, so services that are effectively moving from Hemel to St Albans, that includes hepatology, ear, nose and throat, colorectal, general and vascular surgery, and urological surgery. So those are currently provided on 3 sites, and they will be concentrated to 2 sites, Watford and St Albans. There are 2 services currently provided at Hemel that will be moving over to St Albans to fit with the model of care. So one of those is nuclear medicine, which links to the cancer pathways, which is why it's important to have it at St Albans. And endoscopy and cystoscopy procedures will also move from Hemel to St Albans, which is again about the focus on cancer services, and there are benefits to having those services co-located with surgery. Urgent endoscopy will continue to be provided at Watford. So in the opposite direction then, services that are moving from St Albans to Hemel Hempstead, currently provided on all 3 sites, but in future provided from 2, include effectively the medical specialties, so cardiology, dermatology, diabetes, neurology, older people's care, respiratory and respiratory physiology, and rheumatology. And DEXA scanning, which is currently undertaken at St Albans, will relocate to Hemel Hempstead to support the development of a rheumatology hub at Hemel. And now moving to north to south moves. So there's only one north to south move, which is effectively the fracture clinic. This service moved from well, pre-COVID, we were delivering fracture clinics at Watford and Hemel, and during COVID, we moved the service to St Albans, which was our green site, and we have recently developed an orthopaedic centre there. This is as much as possible a virtual pathway, with patients only called in to see the doctor if it's assessed as necessary on reviewing the x-rays. The plan in future, though, is to co-locate the fracture service with the emergency department at Watford, and to continue to offer virtual appointments where that's clinically appropriate. And that will mean that all the orthopaedic trauma patients, orthopaedic cases that result from an accident or injury, are cared for at Watford, where we've got the full range of clinical staff and facilities for that type of care. Planned orthopaedic surgery will take place at St Albans City Hospital, unless it is complex, in which case it will be at Watford. And that's either the surgery that's complex or the patient who has particular needs. So moving then to looking at things that will move from south to north, so things that are currently provided at Watford that in future will be provided at either Hemel or St Albans. So orthopaedics we've already touched on. We've got a new outpatient hub at St Albans that came into place over the last year, and it's been working really well and brings lots of benefits, and our intention is to keep that service based at St Albans. So the majority of orthopaedic outpatients will happen at St Albans. And then diabetes, rheumatology and cardiology, and indeed respiratory, they will continue to be provided at Watford, but smaller, fewer number of clinics, because we'll be moving more specialist elements of care or things that would benefit from being in the hub at Hemel to Hemel to support that multidisciplinary, multi-specialty one-stop model. So this slide just says what things are not moving. So gastroenterology, audiology, clinical oncology, obstetrics and maternity, so the antenatal and postnatal parts of the pathway, plain film, X-ray and ultrasound will continue to be available on all 3 hospital sites. And then likewise, outpatient diagnostic services that continue to be provided at Watford and Hemel, general medicine, haematology, neuro, stroke and children's services. So those specialties not currently provided at St Albans, and that's a no change position. Further to that, these are services that are effectively currently provided at Watford and St Albans and will continue to be provided at Watford and St Albans. So medical oncology, ophthalmology, pain management, upper gastrointestinal surgery and gynecology. In our original paperwork, we showed a small amount of gynecology activity at Hemel, but on further investigation and discussions with the clinicians, that's been historically a very small number and may in fact just have been a coding error. So effectively gynecology, no change position, continue to provide at Watford and St Albans. And breast surgery and mammography, our breast centre is currently at St Albans and that will stay. These are the services that are currently only provided at Watford in terms of outpatient and diagnostics, and these will continue to be provided at Watford. So we have the specialist TIA clinic at Watford. You need a really quick turnaround. You need to see patients really quickly if there's a suspected TIA. So we need to concentrate those services onto the acute site. Oral surgery, gynae oncology, so cancer treatments for gynecology at Watford, and we have a cardiac MRI, which is very specialist diagnostics equipment, and that is provided at Watford. On the subject of diagnostics, though, we are strengthening diagnostics across the 3 hospitals. It's really important part of future health care delivery. So MRI will be available at St Albans. We've actually just opened one as part of our COVID response in a temporary facility, but in the longer term, absolutely plans to retain and develop MRI at St Albans as well as Hemel and Watford. CT likewise on all 3 sites, and then fluoroscopy, currently only available at Watford, will in future also be provided at St Albans to support the model of care. Over to you, Louise.
Thank you very much, Helen. So this is an engagement plan just to show you our proposed timeline. So we're in the 2nd phase of our public engagement, which will continue until the end of June. And during this time, we are meeting with yourselves, with staff. We have a public meeting tomorrow, and we are also asking people to fill in a feedback form. So the link to that will pop up at the end of this presentation. And I believe we've sent it round already to the Stakeholder Reference Group. And we are also conducting some focused interviews, particularly around the north to south service moves. So really trying to understand the issues behind the travel when people from Hemel and St Albans are coming to Watford for services, and also when people from Watford and 3 Rivers are travelling to either Hemel or St Albans City Hospital. And we are also looking at running the same sample, but across a more representative sample of the population. So just using a market research company to balance or to look at to see if there is further balance to be gained from looking at a sample of people that is more representative of the geography we cover and all the other demographics. So that will just be an interesting reflection on the feedback so far. And your feedback is very important. It does get compiled, it gets put into a report which is considered by our board and also the CCG board, and they will look at that when making decisions about the clinical brief. And you will see that that is work that the board will be doing in July. So all very important to hear from you and to understand what you have gained from the information we've given you so far. And many ways to get involved, and thank you for past invitations. We're happy to come out to you again. I should highlight that during this period of public engagement, the theme is very much our clinical services. So all the information that we have given you, either through the public meetings which have been recorded and are online, or via the engagement documents. And that is very much about our services and our proposals for our services. So we aren't intending to come out and speak to you about the site feasibility study or the reasons why we have chosen a 3-site model. What we do really want to engage on is the services and the proposals that we have set out. So as I've mentioned, there is a feedback form. The deadline is the 30th of June at midday, and you do have details there to get in touch with us to ask us to come out to community groups. And then there is also a link, and you can find the feedback form if you follow that link, and we will send you the link as well. So we would like to open to any questions, and thank you for those questions that have come in already. And if you can keep them coming via the chat function, that would be great. I'm going to start with one for Freddie, which is a question that has come up before, and it's about the cancer services. So we've talked about St Albans as a centre for planned surgical care, but we know that a lot of you are hearing about Mount Vernon, and I've got a question about how the services are split between Mount Vernon and potentially at Watford General Hospital and St Albans City Hospital. So Freddie, if I can ask you to explain how those service models could look across those two hospitals, please. Thank you.
Right, thank you, Louise. I think the first point is that a lot of the cancer workup is all done by the specialties without involvement of oncologists, and an awful lot of patients are referred in. Mercifully, the vast majority of them actually don't have cancer at the end of the day. So if you take something like gastroenterology, patients referred in suspected cancer with colorectal cancer, it's probably less than 15% of patients who will be diagnosed with the cancer following colonoscopy. Something like prostate cancer with raised PSAs, we're looking at a positive cancer rate of around about 30%. So the vast majority of patients actually won't have cancer and don't need oncology input. And even those that are diagnosed with cancer, a lot of them actually will be dealt with by the surgical teams themselves, rather than actually needing to have radiotherapy or chemotherapy. So the actual percentage of patients that have to go on to see an oncologist is a relatively small number. The issue then is if you do require chemotherapy. Now, most chemotherapy can be done as an outpatient, but one of the major risks of chemotherapy is that you can become what's called neutropenic, where your body's immune system shuts down completely and then becomes very, very susceptible to infection. One of the key components of chemotherapy is having access for those patients to attend intensive care, because they may need support, and patients can be very, very unwell. So that is one of the key components of Mount Vernon moving to the Watford site is that they have access to the acute facilities needed to deliver full-scale chemotherapy. The radiotherapy is an integral part of the cancer services, and effectively that needs to be managed by the oncologist. You've got the oncologist delivering the chemotherapy from an acute site. It effectively follows that radiotherapy needs to be delivered there as well, although there is a broader question for Mount Vernon about whether there is satellite radiotherapy units in the further north of the patch, because that would facilitate services for patients who are travelling from as far away as Harlow to Mount Vernon. So I hope that answers the question about the integration between Mount Vernon and the cancer services. But we're doing a lot of joint oncology clinics at St Albans already. So the oncologists will come across and still be seen as part of the especially urology. So we do a joint clinic at St Albans, and it's only if you have to have radiotherapy or chemotherapy that you actually go to Mount Vernon. So the outpatient component is already facilitated.
Thank you very much, Freddie. Helen, can I come to you with a question that came in at the start of the meeting, which is about a specific pandemic isolation unit, like the one that is being created at Hull. Do we have any plans to create such a thing within our new build at Watford?
Thank you very much, Louise. Our preferred option for Watford is for all of our clinical facilities to be in new build hospital, and that gives us a fantastic opportunity to really get kind of state-of-the-art building design, ventilation, all of those things in place, and the clinical teams have given a lot of thought to that, and the design teams likewise. Specifically, so I had a quick look at the link from Hull, which is looking at an intensive care unit. Obviously, we will have an intensive care unit within the new hospital. It will have state-of-the-art ventilation, all single rooms, everything that you could possibly imagine to make that facility as good as possible and completely safe from an infection control point of view. In addition to that, we're planning to have an infectious diseases ward. Again, that will be all single rooms, fully ventilated, with what we call both negative and positive air pressure. So that will be a specific infectious disease ward. Freddie's already mentioned that we're going to have a significantly increased number of single rooms. They won't be quite to the same spec as ITU and the infectious diseases ward, but will nonetheless really help us manage infection prevention and control. Likewise, in maternity and paediatrics, the facilities will be all single room, and again, that will help with infection control. And then finally, it's important, I mean, we're really giving this a lot of thought, but we will also be building in some isolation cubicles into our emergency department. So patients coming in through the front door of the hospital who are suspected to have infectious disease will be able to be treated there. And then last but not least, our designer that's currently looking for Watford has got 3 what we call ward fingers, and they will be able to be completely self-contained. So managing a small amount of infectious disease through the hospital will be covered by what I've just described. If we found ourselves back in a pandemic situation, and at the peak of the pandemic for us this year, we had more than 300 beds occupied by patients with COVID, what we will be able to do is take a whole one of those ward tower blocks and make that the infectious diseases unit, and have all of the patients cohorted there. So yeah, I mean, I know I've given quite a long answer, but the quick answer actually is yes, we will.
Thank you very much, Helen. Freddie, can I ask you to describe how gastroenterology will be provided across the 3 sites, particularly reminding us what the plans are for endoscopy, please? Thank you.
Right. The gastroenterology effectively falls into sort of 3 categories. There's the acute component, which is patients who are attending typically with either gastrointestinal bleeds or with very acute exacerbations of often chronic conditions such as Crohn's or ulcerative colitis. So we need to have an endoscopy facility at Watford to facilitate the emergency management of patients, because some patients will require emergency gastroscopy or colonoscopy. And that needs to be supported by having interventional radiology and emergency surgical teams on site. So there'll be an acute endoscopy service available for those patients who admit acutely. The next key component of gastroenterology is the diagnostic component, which is either looking in the colon with colonoscopy or into the esophagus and stomach with endoscopy that way. And that's really a diagnostic facility. And the plan is that that dovetails in with the general surgical component, who also carry out this work, and that will be done at St Albans Hospital. We'll also have the advantage of immediate imaging for staging patients who are diagnosed with cancer or other conditions. And finally, there's the third component, which is the very long-term component of gastroenterology. These are the conditions such as Crohn's or long-term irritable bowel syndrome, who you're not hugely reliant on either any acute endoscopy, but these can be managed at Hempstead as part of the long-term medical conditions unit. And some of these patients will require infusions of some of the newer drugs that suppress these inflammatory conditions. And in conjunction with the long-term management plan for Hemel, these patients then can be managed at Hemel Hempstead Hospital. So it's really just divvying up the three key components of gastroenterology onto the most appropriate site, which is how the future will be for gastroenterology.
Thank you very much, Freddie. Helen, I'm wondering if you can give us an update on the timing of the build at all three sites, just an idea of what might happen first and the timeline that we're working towards.
Yeah, okay. So we're currently at what we call outline business case stage, and we're hoping to complete that outline business case in the next couple of months, 3-4 months, and submit it through to the new hospital programme and regulators. Our timeline as it's currently set out says that we expect them to spend, following approval of the business case, which might take a bit of time to work through because obviously it's a very large investment that we're looking at. There's then a period of about 18 months for the full business case, that's the point at which we go out to tender and secure a construction partner. And then it's a 3-year build programme, really from starting construction on the site with some enabling works running up to that. So roughly 5 years from here, but there is an awful lot hanging on the approvals process and how long that takes to work its way through. At the moment, we're doing a single outline business case for all 3 hospitals for the investment required, and for digital investment to support the new models of care and to make the hospital as modern and innovative as possible. We expect after outline business case stage to probably separate out into 2 or more full business cases, one for Hemel and St Albans combined because those changes are interlinked, one for the main redevelopment of emergency care at Watford, and then potentially a series of full business cases for specific digital technology innovations that we would like to implement well ahead of the 5-year timeframe that I've just described. And potentially Hemel and St Albans could go a little bit faster because the builds are smaller, and we'll be looking to see if we can secure the funding and permission to take those ones forward a bit quicker than what I've just described.
Great, Thank you very much, Helen. Freddie, clinical question for you coming up, but before I ask you about dialysis and renal services, Freddie, I'd just like to address a couple of questions about travel and transport access, buses, always very common theme. It was during our first period of public engagement. So we will be doing some detailed work with local authorities, with bus companies, looking at the provision of public transport as well as parking costs. We always look at the costs of parking locally when we think about imposing charges. So there is going to be a lot of work on all aspects of travel and access public transport. So if that is something that you are interested in, we will be looking for people to join a reference group where we can test out some of our ideas with you. And if you email a normal address and register your interest, then we would be very grateful to have you on board with us to look at that. Freddie, if I may, I'd like to ask you a question about renal and diabetes service. And the question is, if diabetes is moving to Hempstead, will there still be dialysis at St Albans? Because often those services are linked.
Right. Well, the answer is very clearly yes. Dialysis services are actually supplied as an outreach service from east to north Herts to St Albans, and the satellite unit at St Albans will be staying at St Albans. I appreciate that renal failure can be a complication of diabetes, but hopefully it's only a minimal number of patients. But that facility at St Albans for dialysis will stay, as will the facility at Watford, which is actually managed by the Hammersmith Hospital renal services there. So we have effectively two different providers providing renal services to West Herts, and both their satellite units will stay in their current sites.
Thank you very much. Helen, I've been asked a question about ophthalmology, which is a service that is currently provided at non-hospital locations. So I think there is some in Watford town centre and possibly other areas in Dacorum and St Albans. And I've been asked, will those services be brought back in-house? And if patients are unhappy with aspects of the service, what can we as an organisation do, or the CCG do, to make sure that the quality is as it should be? Thank you.
Thank you, Louise. So yes, we have a model locally which involves a private sector organisation and community ophthalmologists delivering parts of the ophthalmology pathway, and then secondary care, our consultants providing the more specialist secondary care level of outpatient support. The primary community ophthalmology service is commissioned by the CCG, and effectively it's not our decision as it stands who provides it. Having said which, we've got actually a good working relationship, I believe, between our clinicians and that service. There are some governance arrangements in place. If local residents have got concerns or have had experiences that they're not happy with that service, they should definitely flag them through to the clinical commissioning group in the first instance, and then they can be picked up and reviewed through that joint governance arrangement. We are planning to have another look at the whole ophthalmology pathway. It is it's an area with high levels of need and demand, and kind of growing as the population ages. But it is really important that the skills of our secondary care clinicians are really focused on the patients with the most complex needs. So I imagine there will always be some sort of partnership model, but we're very keen to make sure that we're learning and listening to feedback and picking up any concerns that people might have. So do please let us know, either to us and we can pass it to the CCG, or directly to the clinical commissioning group.
Thank you. Helen, I think this is probably a question that you can answer about outpatient pathology clinics, and probably also useful to talk to people about blood tests and phlebotomy, but can you explain if those services will be at all 3 of our sites, please?
So I might have to defer to Freddie on the outpatient pathology clinics, because I'm not clear enough in my own mind what that is. But to say that obviously pathology support and analysis of all of the tests that get taken is really important, and we're working with partners across the whole of the Herts and West Essex area at the moment to review our pathology services and get a new service provider in place with the most modern and up-to-date pathology equipment. In terms of phlebotomy, blood tests, yes, we expect to continue to provide those on all 3 of our hospital sites, but we're also really keen on working with, again, the clinical commissioning group to see whether there can be more provision of blood tests in primary care settings, because you shouldn't really need to have to come to a hospital to have your blood taken. So we'd like to develop that service further. And I'm going to pass to Freddie on the subject of outpatient pathology.
Thank you. A little bit confused exactly what you mean by outpatient pathology appointments, because it's sort of pathology is sort of universal within all the specialties. I think from the main ones, if we're talking about things like hematology, and then they will largely provided on the Watford site. But I think you've already explained about phlebotomy, Helen, which will continue, and you've explained about the model for the whole ICS and pathology delivery. So I think we just have to assume that most of it was referring to phlebotomy, which will continue. Now, and if it's not phlebotomy, then there will be, I'm sure, collection hubs in each of the 3 hospitals for specimens to be delivered, so that they can go to a potentially a centralised pathology service.
Thank you, Freddie. I've been asked a question which I can't really answer, but I'm sure Freddie can. It's about fluoroscopy and what is fluoroscopy. Well, the meeting was progressing, I did find this line on the internet. It's on an NHS site, so I hope it's reliable. But it says, if an X-ray is a still picture, fluoroscopy is like a movie because it allows the clinician to see organs and parts of the body and blood flow in real time rather than as a still image. But that's probably horribly dumbed it down, Freddie. So I wonder if you could maybe talk about fluoroscopy in a better way than I just have.
Okay, well, fluoroscopy is actually really quite old-fashioned. It's best thought of, as you sort of alluded to, is basically video X-raying. So for something like urology, we would put a catheter into you and then fill your bladder up with fluid that then shows up on an X-ray, and then effectively we get you to an X-ray you at the same time, so we can see how the bladder contracts and whether any urine goes up to your kidney. So it's a sort of real-time video X-ray. It's relatively old-fashioned technology. So it's one of the things that we probably do less of nowadays than we used to do 10 or 15 years ago.
Thank you very much. Helen, I have a question for you, which touches on changes that are going on in the wider health system about the clinical commissioning groups coming together. And I'm wondering if you can answer it in the context of all the changes that we're making to our sites and our services, and give us a flavour of how that's all going to come together and how we can take the benefits from those changes and pass them on to our patients.
Thank you, Louise. So yes, currently there are 3 clinical commissioning groups across Herts and West Essex. So that's Herts Valley CCG, East and North Herts CCG, and West Essex CCG. The questioner is right that those 3 CCGs are effectively being merged into a single CCG for Herts and West Essex, although there is a bit of a discussion about West Essex at the moment, but we'll leave that. In many ways, that's an administrative NHS kind of process that doesn't necessarily affect the day-to-day responsibilities of the CCG and how we will relate to them. Having said which, we are working together in West Hertfordshire to create something called an integrated care partnership, which is really about all of the providers of care. So the trust, West Herts Trust, CLCH, which is the community services provider, Herts Partnership Trust, which provide mental health services, the local authority who provide social care, and with GPs to work together to say, how can we deliver care that is better, which is more joined up, which is more preventative. So all of the things that we've talked about today and through the engagement programme around redesigning care is all done in partnership with those organisations, with really a view to get a really strong local West Hertfordshire way of working, way of delivering care, and increasingly over time, decisions that in the past have been made by the clinical commissioning group will be kind of devolved to the integrated care partnership, so that we will have a collective responsibility for making decisions about the best way to spend the money that's available to support health and care, redesign care and deliver care. So yes, there are changes coming. The formal merger of the CCG is actually due, I believe, next April, but it's going to be more evolution than revolution, and actually it won't make a huge amount of difference, the fact that the three CCGs are coming together into one management and leadership decision-making structure.
Thank you, Helen. Thank you very much. So there is just one sort of follow-up question, which is about gastro and what would happen if a patient came into Watford A&E. So important to note that the unplanned endoscopy, urgent endoscopy and the gastro service is one of the components that is definitely remaining at Watford. Perhaps if we can go back to the orange slide, the slide with the orange diagram in, if you wouldn't mind, and that will show endoscopy. So Watford General Hospital is going to have this expanded emergency department, and all the services that would interact and that would be there for patients who come in via A&E will be at the site. It will all be one new large clinical building. So really thinking about how services fit together. So please don't be confused by the conversation about endoscopy moving from St Albans to Hempstead. The services that you would need as a patient coming to accident and emergency will absolutely be here for you at Watford. So I hope that clears that up. And all the engagement documents that we've provided until this point give lots of detail about exactly which services are moving and which are staying put. So that brings us just approaching midday. So thank you very much for being with us this morning. Thank you to Helen and to Freddie for their time today. And yes, I would urge you to go back and refresh yourself on all the information that we've given you if this has posed more questions. And please do complete the feedback form, and that just helps us understand what we've been able to make clear and what we may still need to clarify. So we will be in touch with another meeting. We hope some of you will want to join the steering group to really get under the skin of some of those transport, travel and parking issues. We know they're important to you, and we hope that you are very well. Thank you very much.